नमस्ते, मेरा नाम लक्ष्मीकांत पांडे है। हम बेलूर में रहते हैं। मेरे पिताजी ब्रज मोहन पांडे, उनका कुछ समय से स्पाइनल कॉर्ड में पेन हो रहा था, जो मैंने बहुत सारे डॉक्टर को दिखाया, बट वो लोग पता नहीं कर पाए उनके बैक में किस चीज़ का पेन हो रहा था। वो लोग अच्छे से बीमारी पकड़ नहीं पाए और उससे उनको बहुत ज़्यादा तकलीफ हुआ। फिर हम लोग नारायणा हॉस्पिटल के बारे में पता चला, फिर हम लोग उनको यहाँ लेके आए। यहाँ पे हम लोग डॉक्टर सायन घोषाल से मिले।
डॉक्टर सायन घोषाल ने हमें बहुत सारा टेस्ट करवाने के लिए बोला था। मिनिमम 3 से 2 डेज लगा टेस्ट करवाने में। डॉक्टर सायन घोषाल बोले कि इनको मल्टीपल माइलोमा हुआ है, हेपेटाइटिस B+ हुआ है। जो सारे डॉक्टर को दिखाया गया था उन्होंने बोला कि वो बच नहीं पाएंगे, पर एट लास्ट डॉक्टर सायन घोषाल 2 वीक्स में उनको अच्छे से ठीक कर दिए। बोला जाए कि वो मिरेकल है। ये बात हम लोग ने एक्सेप्ट नहीं किया था कि वो उन्हें बचा पाएंगे, बट एट लास्ट वो अभी बातचीत कर रहे हैं हम लोग के साथ, वैसे हैं। अभी उनका कंडीशन पहले से बहुत बेटर है।
हम लोग डॉक्टर सायन घोषाल का बहुत बहुत शुक्रिया अदा करना चाहते हैं।
और इनकी हॉस्पिटलिटीज की फैसिलिटीज बहुत अच्छी हैं। हम लोग ने यहाँ पे 2 वीक उन्हें रखा था। 2 वीक में उन्होंने हमें बहुत अच्छे फैसिलिटीज दिए और डॉक्टर सायन घोषाल हमें अच्छे से ट्रीट किए और हमारे फादर को पहले ऐसा नॉर्मल कर दिए।
Hi, good afternoon to everyone. Myself, Dr. Sayan Ghoshal. I'm a consultant hematologist and hemato-oncologist in Narayana Super Specialty Hospital, Howrah. So today I'll share about some thoughts regarding multiple myeloma, a very commonly bone marrow proliferative malignancy, what we generally see. How the patient presents. These types of patients, generally these are the elderly patients, aged more than 50 years. So there are some cases less than 50 also, but generally we see in the age group of 50 to 70 years, patient present with severe anemia and backache, and the anemia will be maybe a sudden onset or maybe a 1 or 2 months like onset of the anemia, and along with that there will be a severe backache, and sometimes due to severe body ache patient is bedridden, and some of the cases even we have seen there are dyselectrolytemia. Calcium will be high in those patients, and overall the condition, that the performance status what we tell, that will be low in this kind of patients. And second thing is, this kind of patients comes with us, what we generally do, the basic investigations are a CBC, that is the complete blood count, with a peripheral smear examination. Along with that we do LDH, calcium, liver function test, and all the electrolytes. In liver function test, one thing is very important here, there will be a dissociation of the albumin and globulin. Generally we see albumin is high and globulin is comparatively low, but in this type of patients the total protein will be very high and albumin will be low and globulin will be high. So there will be a dissociation of albumin and globulin ratio. Second thing is, there will be high calcium value, so that is hypercalcemia, and patient may present with anemia, that is hemoglobin will be very low. Even in some of the cases I have seen hemoglobin less than 5 also. So there is an important criteria what we tell, that is CRAB criteria, CRAB. C for hypercalcemia, A for anemia, B for bony pain, and R for renal dysfunction. These types of patients also present with acute kidney injury. Even in some of the cases AKI is also present, so creatinine will be high. So after doing all this basic test, we do a bone marrow test, that is bone marrow aspiration and bone marrow biopsy. Along with that we generally send a fish for multiple myeloma panel to denote the different types of genetic mutation what we generally see in multiple myeloma, and in those genetic mutations, based on that we can say this is high risk cytogenetics or standard risk cytogenetics. In bone marrow what we'll see the percentage of plasma cells. If the percentage of plasma cell is more than 10% along with any one of the CRAB criteria and myeloma defining agent, then we can tell it is a multiple myeloma. And if the plasma cell is more than 60%, then straight away we can tell it is multiple myeloma. Along with that, few of the other tests what we do, very important in all together, it is called myeloma protein panel. Under that we'll see the different types of immunoglobulin, IgA, IgG, and IgM. Along with that, one single test for diagnosis of myeloma is very important, it's serum protein electrophoresis. In SP we'll see the M band, that is the M spike. Along with that, immunofixation electrophoresis, where we'll see which type of things are present, that IgA lambda or IgG kappa, like those. And another thing we see beta 2 microglobulin. So we have generally 2 criteria, one is ISS staging and one is revised ISS staging. ISS staging is done by based on the values of serum albumin and beta 2 microglobulin, and RISS we consider another 2 entity, that is LDH, along with that cytogenetics, that what we can take from the fish for multiple myeloma panel. So that is very brief about the diagnosis. diagnosis, then we go to the treatment. Based on the clinical status, the creatinine value and the calcium level, we generally formulate the treatment. And there are triplet therapy we call. So there are certain therapies like VRD, that is bortezomib, lenalidomide and dexamethasone. If the creatinine value is normal, we generally go with VRD. Otherwise, we may start with VCD in kidney compromised patient, and even we can start with VTD, that is thalidomide, dexa and bortezomib in some of the elderly patients. So this is the primary therapy what we start, triplet therapy, and there are several therapies. If this regimen, after generally we give 6 to 8 cycles of this regimen. I personally follow a regimen where like after 4 cycles we repeat a myeloma protein panel to see for the response, and after that, like based on the response, we formulate the further therapy. Thank you. We repeat a myeloma protein panel to see for the response, and after that, like based on the response, we formulate the further therapy. Thank you.